So, hi everyone. I hope you slept well. You recovered from yesterday session. As you can see, Doreen and myself are still alive. The session was very good, was very well attended. Thank you all. I hope you also had taking some notes because these sessions will be used for your assessment later this year. And today I would like to welcome you to a session on training and colorectal laparoscopic surgery. And this webinar is, as you know, under patronage of Professor Abe Fingerhut, who is
Hi, everybody.
Our great friend, and you know him. Some of you attended this writing scientific surgical paper 2 years in a row. This year we missed and hope to have it next year.
Hopefully, yeah.
So, Abe, would you like to say something before we introduce Professor Tinri?
Yeah, I'd like to welcome everybody and say that I'm very enthusiastic about this webinar, and I think we have to thank our friend Pejda for organizing such a webinar. It's a very instructive way of getting messages across, and I just hope it's going to be a great session. I'm sure I saw the program. The program is just fantastic. There's a wide array of excellent speakers, and I'm sure this is going to be a memorable event. Thanks again for the organization.
Okay, we have our, this is my colleague, Mr. Charles Cini. He's one of moderators for this session. He just, as you know, that we work on Saturday, so he's just finished his word round and he walked in. Charles, if you want to say a few words.
Good morning, everybody. It's my pleasure to be part of this, and I hope it will be a fruitful 2 hours.
Yeah, I think we should start. We have Professor Sean Tinri from Royal College of Surgeons in Ireland, Professor and the Dean of Surgical Education, who's going to talk to us about the college's response and training in COVID situation. Sean, here you are.
Thanks, Pedja, and good morning, everyone. Thanks very much for the invitation. I'm sitting here, courtesy of Zoom. I'm actually sitting at home, but courtesy of Zoom, this is our new RCSI training building in Dublin, which Pedja was due to visit this week with some colleagues, this week or next week. That's been postponed, just like everything else, for the next while. And I was going to share with you some of the experiences we've had in relation to how our college has been involved with and helped in the response to the COVID-19 crisis in relation to Dublin. So I have some slides. Is it easier for me to share them from this end or from your end? What's the best, Pedja? I can share my screen, I think. Let me just see. Now, can you see that? I'll assume you can.
Yep, now it's okay.
Okay, right.
We can see it.
Great. So it's good to be back in Malta, even if it's virtually. And I do hope to get to visit you all in person before too long. And I know I've met some of the trainees in the last few years. In terms of RCSI, it's similar to, but it's different from some of the Royal Colleges in the UK that many of you would be familiar with. It's similar in that we run exams jointly with those colleges. That's our membership exam or fellowship exam, which is intercollegiate. Courses for trainees and fellows, some of which we've run in Malta with Pedja. Providing guidance and continuing medical education for those in surgical practice and other supports to fellows. Unlike the UK, though, RCSI also has a medical school. It's Ireland's largest medical school. And on Wednesday last, 321 new graduates graduated online to join our medical workforce in Ireland and abroad. There's also medical campuses in Bahrain and Perdana in Malaysia. And we have schools of physiotherapy, postgraduate research, pharmacy, and postgraduate nursing. And just this year, it became Ireland's newest university, and it's a unique health science university in Ireland, just established. So also, unlike the UK, we run a single national training programme in all 10 specialties, 10 surgical specialties, and in emergency medicine, and we're approved by the Medical Council to run this programme. So we effectively run one single residency programme for the entire country across about 20 sites. We're also licensed by the Medical Council to run postgraduate professional competence training, which would be equivalent to what's known as revalidation in the UK. And it is mandatory. It's required by the Medical Council as part of maintaining registration, but we operate the scheme, provide the education, and help practitioners demonstrate that they're compliant with it. So next slide, how do we do that? So looking back this time last year, we had a lovely long hot summer here, and the world we're currently dealing with seemed very far away. In terms of the health system in Ireland, life expectancy at birth at that time was actually pretty good. It's over 82 years. We're 7th place in Europe, 2 places behind Malta, and at least a year above the EU average. And in fact, there's been a significant improvement in our position over the past 30 years. And I think that probably has much to do with economic development rather than healthcare, but perhaps healthcare has played a role. And I would say it's largely seen in Ireland has been due to our EU membership. And unlike the UK, support for EU membership in Ireland is extremely high. And in polls, it runs somewhere between 92 and 95%. We also have a very young population, and the fertility rate in Ireland is one of the highest in the EU. And our predicted population growth over the next 25 years is one of the highest in Europe due to both our fertility rate, but also because of increasing immigration. And what that means is that our population is relatively young, and that we haven't yet had the increasing numbers of older people with increasing reliance on our healthcare system. 82% of our population report excellent or good health. That's the highest in the EU. But we do have some healthcare problems which COVID, I suppose, started to expose. We have the lowest number of bed numbers per head in the OECD and amongst the lowest number of specialists and GPs. So we have limited bed capacity, and this has resulted in longer waiting lists. There's over 12,000 patients at the start of this time waiting for inpatient or day case procedures. So they're elective things like lap chole, hernia, varicose veins, hip and knee surgery, cataract surgery. And we also, because of the lower number of specialists and GPs, have very long waits for outpatient appointments. So 10% of our population are on an outpatient waiting list at any time, and 150,000 of those are waiting more than a year. And finally, for emergencies, we've had a problem accommodating emergencies into hospital beds in a timely fashion. And in December of last year, we had the highest peak we've ever had of patients in the morning across all our hospitals waiting for a bed, where there was 300 patients on hospital trolleys waiting for beds. So while we had some positives in terms of our population demographics, particularly given the propensity of COVID to affect older patients, we also had some systemic weaknesses. And we also had an interesting political context. We had a general election in February. The sitting government lost in that election, and there was a hung parliament. And to date, 100 days after the election, we're still being governed by a caretaker government in place, with no new Taoiseach, which is our Prime Minister, and no new ministers in place. And this probably actually allowed them a bit more latitude. They weren't dependent on their performance for re-election. And it allowed them to ignore political concerns and follow very closely on public health advice, which is what we've done here. So we first saw our first recognised cases in March. I think, like other countries, we're starting to realise that there were probably a low level of cases circulating in the country back in as far as December, but it was recognised in early March. We closed down the schools on the 12th of March, closed museums, libraries, banned large gatherings, encouraged people to work from home, and scheduled surgery was cancelled at that point. And a week later, we went into full lockdown with essential work and travel only, 2 kilometres from your home only from exercise and food shopping. And this was part of the flattening the curve and managing the healthcare response. So we were in full close down for St. Patrick's Day. This is O'Connell Street, St. Patrick's Day, no parade, empty streets, and they remain almost empty to this day, with the first phase of release of the lockdown starting for us on Monday. So in terms of the healthcare response, and I suppose our response, I thought we might just look at 4 areas: training, surgical practice, service delivery, and professional development. And I'd look at it in 3 phases. Phase 1 being that initial response. Phase 2, which we're just moving into now, which is an attempt to get, if you like, non-COVID healthcare back on track. And phase 3, which is sometime in the future, I'm going to talk about only briefly because I don't really know what that's going to look like. I'm not even sure what phase 2 is going to look like. So in phase 1, the goal was to manage the exponential spread of the disease. So we wanted to protect healthcare capacity. So we had emergency surgery only, no outpatient facilities, and the redeployment of staff, and mainly junior surgical staff, into medical wards or into critical care areas to act as relief and support there. There was a big issue of protecting staff and the use of PPE, and we had a similar problems to what you've seen over the world about concerns about availability of PPE. And Aer Lingus were diverted to I think put in place 100 flights to China to bring back PPE to fill that gap. We've a budget this year of about €1 billion for PPE over the course of the year, which is about 10% of our healthcare budget is going to go on PPE over the next year. And the goal was protect patients to minimise risk and exposure, particularly as we didn't know fully what those risks might be. So the impact of this is just this is our own vascular surgical units data, so it's small numbers, but just to give you a feel for the impact. This is between the 13th of March and the 26th of April when we were in full lockdown. So our overall activity fell by 72%, elective activity fell by 94%, and most of what we were doing was urgent or emergency vascular cases and things like minor amputations and indeed major amputations. Several diabetic patients turn up with quite advanced disease, partly because of difficulty with access, requiring major amputations to control their infection. This is data from our electronic logbook. So our trainees, a bit like trainees in Malta, use an electronic online logbook, which we can view in real time and see the data on demand for all over the country. So this shows core trainees, that's years 1 and 2. Their logbook activity fell by 1/3 in March and by nearly 80% in April. And we continue to monitor this. And this is a concern for trainees where there's now a significant portion of their time in years 1 and 2 that have been hugely impacted. I think it probably is also true of higher trainees, and we're waiting to see their data in due course. In terms of how we've responded to it, on the training front, we accelerated our national selection program. So our interviews were scheduled for March and into early April. We brought all that forward by 6 weeks and conducted all our interviews in the space of 10 days at the beginning of March. And that allowed us to do the interviews face to face and appoint people into the next stages of the training program. The membership and fellowship exams have been deferred, and it's now not planned to hold any exams before November. And that's under review, and JCST issued guidance yesterday suggesting that they will issue a timeline in July, but it's not likely to be any exams before November. And given the restrictions on travel and the potential for quarantine and so on, there's going to be significant logistical challenges in organising exams for the foreseeable future. In terms of logbooks and assessment of trainees, we've arranged to assess trainees remotely using Zoom-based webinars like this. And it's been agreed that a flexible approach will be taken to logbooks so that trainees won't fail to progress because of logbooks. But equally, we will have a problem with trainees arriving at the end of training programs if they haven't reached the minimum levels of experience to be safe. And we're still exploring how we might deal with that. We've recognised that trainees might be redeployed, and indeed some of that might be a valuable learning experience for surgical trainees spending time in critical care areas. Might be quite valuable for them. And we have encouraged them to keep a record of this experience. It is a bit of a challenge for us. I've spoken before in Malta about the fact that we use a very structured scoring system to make selection and progression as fair as possible. And that's based on the numbers of operations and logbooks and other parameters. And we're exploring how we're going to look at trainee progression and trainee selection when we won't have data like that. We think there might be problems with trainees who are due to go on fellowship in July with restrictions on travel, either delays or deferments. And we're hoping that we'll be able to accommodate those. And one of the suggestions is that we might proleptically appoint those people as consultants, allow them start work in Ireland and then go on their fellowship when that becomes available. And we've had significant issues with trainees needing to take time off work for childcare, and all childcare facilities in the country have been closed and remain closed. Those have become ill. On my own team, a registrar, an SHO and an intern have all been sick with COVID and all have had time off. And then there are those who are looking after family members or have family issues that make all of this more difficult. So in terms of responding to that, we've used a lot of webinars like this, and yesterday I spent 6 hours in front of a computer screen. Most of our specialties are running journal clubs, case discussions, briefings on key topics, and indeed joining international conferences, which increasingly are moving online, and most of the conferences that I've seen up towards October, November have already been cancelled or moved online at this stage. We're looking, as I mentioned, at the logbook and how to use that data to provide some intelligence on what's happened. And we did suggest to trainees about keeping a diary, a reflective diary. The trainees weren't keen on this, and in engagement with trainees, we said, well, if you don't want to do it, that's fine. And we dropped that from our requirements. We felt it would be helpful. I think people felt it would be more of a burden, and we're uncertain how it might be used in future. So we dropped that proposal, although it's in use in the UK. I don't know about you, but I'm drowning in information. I get emails, WhatsApp groups, Twitter. It's just never ending. And it's very difficult to sort out the knowledge from the noise, and it changes so quickly. So we have tried to help our practitioners who are drowning in information, which is often conflicting based on little data, and evolving over time, by producing a curated set of resources with web links and documents that people could refer to and say at least it's been filtered through an expert opinion. But it's actually quite difficult to keep that current and up to date. So we've gone from everybody has to use full PPE to selective use of PPE to there can be no laparoscopy, everything has to be open, to there was no surgery of any kind, versus, well, we need to do some emergencies, otherwise people are going to suffer adverse outcomes in terms of cancer. And currently we're in a risk-based approach, and I might talk about that briefly later on, or indeed some of my colleagues might come back to that. We've produced clinical guidance for surgeons, so we've produced policy papers at national level. We have had a problem where each hospital is trying to invent solutions from the ground up. And probably the best example I have is where patients who needed urgent but not emergency surgery, so say cancers, or we've had a patient who required aortic aneurysm repair. And it goes from they need to be swabbed for COVID, to they need 2 swabs, to they need 3 swabs, to they need 3 swabs in a CT scan, to they need to be cocooned at home for 2 weeks before surgery. They need to go into a separate room. And it's all very ad hoc, and it's very little evidence-based. And it's very resource intensive moving these goalposts around. So we've tried to approach this from a national level with some rational guidance. And of course, there will be risk, and there is an increased risk. But like every other clinical risk we face, that needs to be balanced with the risks of not proceeding and not offering surgery. General practice has been under a lot of stress in Ireland, and they've largely gone to a telephone-based service with special hubs provided to patients who have respiratory symptoms in particular, and it's been quite difficult. And they've had very limited access to hospitals, so we've closed our outpatient clinics. We're doing telephone clinics, which have been mixed success. But we have a facility now to link GPs in with surgeons to get some advice on particular aspects of patient care. And that's been quite a positive move, and I think has been popular with GPs. But Ireland being small, no more than Malta, lots of GPs would have my mobile phone number and will ring me directly if there's a particular query they have about a patient or how they need to manage a patient. So there's been a mix of informal and formal solutions to the lack of access to outpatients. And we've run weekly webinars using Microsoft Teams. We've had over 1,000 participants now to our weekly webinars, which are 4 or 5 speakers, a bit like this format, offering their interpretation of the current situation and having time for discussion and engagement on future or likely future developments. We've had a deferral by the Medical Council of mandatory CPD requirements, so there's no enforcement going on, but doctors are still required to engage in ongoing professional development. So we've tried to move this online, and certainly one of the big challenges here has been teleconsultations, and having to do things by telephone brings a new challenge, particularly in relation to patient care issues for sick inpatients where there are no visitors of any kind whatsoever allowed in the hospital. So there's no face-to-face contact with families happening at all. And we produced with some of our colleagues a nice course on how to do teleconsultations. And just this week, we're producing one on video consultations, and I can share that link with you. It's open registration. It takes less than an hour. It has some nice interactive animation facilities. And we think it's a very useful refresher course for how best to do telephone consultations, particularly for those who might not be used to it. And we've produced some other resources that we've had for years that were only available within the college. They're now freely available on the internet. And we're working on digitizing some operative videos, and we've a course in basic science for orthopedic surgeons online at the moment. There's been some other initiatives. There was a fundraising appeal for face protection for ICU staff who are actually getting facial ulcers from the PPE, and there was a pack created for that to protect them, and there was a fundraising thing for that. That raised €10,000 in less than 24 hours. I've been involved with the COVID Surge collaboration, which has just been accepted. The first paper has just been accepted for the Lancet. And that again is showing fairly poor outcomes for patients who become COVID positive in the perioperative period. And some of my colleagues in RCSI have been very much involved in the scientific research underlying COVID. And just last week in the Lancet produced a paper looking at a new disease model for COVID based on intrapulmonary intravascular coagulation, which is a nice scientific model and a nice conceptual framework, I think, for going forward. So where are we now? This is our critical care situation from a few days ago. It's improved again. We now have less than 100 new cases per day. Our lockdown is lifting from tomorrow. We have a huge unmet need in terms of surgery, including urgent surgery. And we think it's important now, as does our public health colleagues, to protect patients from neglect of untreated illness like cancers, vascular diseases, and so on, which will have a second impact down the line of COVID in terms of poorer outcomes and increased mortality from those diseases. We're concerned about a second surge and preventing that. And for example, one of the significant challenges we've had has been sick leave amongst healthcare workers. 30% of the positive cases in Ireland have been healthcare workers. A lot of those are not healthcare acquired. We have a big immigrant healthcare workforce. They tend to live in apartments or shared houses with 4 or 5 of them together. And if one of them gets positive, they all tend to get positive. And they often work in the same hospital and sometimes even in the same ward. So we've had to close wards where up to 10 or 15 staff members, predominantly nurses, have become positive. And that's a significant issue. And we're looking at mitigating that risk going forward. But actually, that's very difficult to do. In terms of how we might do it safely, we're also looking at a prioritisation scheme. Pedja mentioned that you're doing something similar in Malta at the moment. And we've looked at how to provide information to patients and indeed information to clinicians to how to factor in the risk of COVID. We're all aware from the Wuhan data and the recent COVID surge data that up to 20% of those who develop COVID in the perioperative period will die. 40% will require ICU and up to 50% will develop significant pulmonary complications. However, most patients won't get COVID, and we need to factor in the risk. So the risk is not a 20% risk of mortality for all patients having surgery. It's only in those who become COVID positive. So we're trying to develop pathways to protect patients, but I think also to explain to them that there is some increase in risk, and for clinicians to have some handle on what that increased risk might be in order to decide what might be appropriate treatments to offer and what it might be more appropriate to defer. And as I said, looking out phase 3, we see that as being probably the end of the summer and beyond. And this will be getting back to things like hip replacements, surgery, which is elective quality of life surgery, but not for mortality risk. And we have the challenge of physical distancing. Currently in my hospital, we've gone from 2 theatres for the last 6 weeks to 4 theatres from Monday. And we're looking at 8 theatres by probably the end of the summer. We're looking at sustaining skills training for our trainees. They used to come into that nice building you see behind me. That's been locked for the last 2 months. Indeed, when we do bring them back, we're going to face the issue of physical distancing, protecting faculty, and the fact that we still have to have all of the protections in place, plus the fact that a health centre with with significant numbers of staff vacancies won't be able to sustain absences from practice as much. We've all heard the warning that a vaccine might not be available for 12 months, and indeed I've heard Dr. Mike Ryan, who's one of Ireland's most famous sons at the moment, say that there might never be a vaccine and that we may have to live with this forever. And I suppose one of the things we have been particularly concerned about is our colleagues in low and middle income countries. For 12 years now, we've worked really closely with the College of Surgeons of East, Central and Southern Africa. We've been working with them to develop their surgical training capacity to expand the number of surgeons. They have 0.5 surgeons per 100,000 population, whereas in Ireland we have something like 40 per 100,000 population. So we've been working to expand the surgical workforce there. Their healthcare systems are very vulnerable and are likely to be overwhelmed very quickly. And there's some signs that's already happening in Tanzania, for example. So our program with COSEXA, funded by Irish Aid for the past 10 years, has had savings this year because we haven't been able to run courses and travel has been limited. And we've actually donated back to our own Irish government some funds which they're really using to fund the WHO shortfall created by President Trump's decision. And I suppose I would still be very concerned about the health impact in those low and middle income countries where resources are so limited. So thank you for your attention. It's good again to be back in Malta. This is a picture of one of my previous visits when I was made an honorary member of the Association of Surgeons in Malta. So Malta is like my second home. And while I'd love to be there, I'm not terribly keen on getting on a jam-packed Ryanair flight anytime soon, but I look forward to visiting you at some stage in the future when things are a bit more under control. Thank you very much.
On Max. Yes, okay. Thank you very much, Sean, for this nice presentation. I think
it was a very interesting overview of the situation in Ireland. If I may ask, during in the surgeries, the emergency surgery you're doing, are you performing any laparoscopic surgery? And if you are, what precautions are being taken to decrease aerosolization?
Yeah, so my colleagues are performing some laparoscopic surgery. There was some concern from the very beginning about the risk of aerosol generation, and I note there's been a paper in the last 2 weeks demonstrating the presence of COVID in peritoneal fluid. So I'm not a laparoscopic surgeon, but my understanding is they do it, and they do that surgery using full PPE, with FFP2 masks, visors, the full protection, but not hoods or things like that. And I think they're using it selectively rather than routinely. So there might be a lower threshold for open surgery in procedures where they think it might be particularly difficult or prolonged. So yes, it's being used, yes, with full PPE to protect from aerosols. And I guess there is some risk of clinician exposure. One of my colleagues did develop it after operating on a patient who subsequently became COVID positive, but he felt he got it visiting the patient in the post-operative period because it wasn't known he was positive, so they were in the room together with no masks or protection, and I don't think it was a perioperative acquisition. So yes, but with significant protective equipment.
I'll be talking about that a little bit later.
Yes, we're going to have a full talk of that and some more insight review regarding this. I would like to ask you this. First of all, to tell the audience if they want to ask a question, we will be taking a question after each talk. It's probably better. But you will have to ask so that our sound engineer will put you online instead of writing down, because yesterday there were some complaints. There were many questions we did not answer because of inter-talks between the faculty. I would like to ask you this, Sean, two questions. Interviews, okay? I understood that you have done interviews faster. We have postponed our interviews, and that was a very good, which we discussed with Mr. Gini about which kind of information you take, because this is enormous amount of new things. They come out from every single source, and I personally tend to read the information sent to me via email only from colleges or societies which are well known, but there a lot of information. Would you have any advice to the young doctors, our trainees, what information and where to look for?
I mean, well, first of all, I would agree with you that there's a lot of confusing information out there in the public domain. So I think it's certainly advisable to go to authoritative sources, but in fact, even authoritative sources are under challenge at the moment. I mean, we've seen the New England Journal produce a paper with, I think, a couple of dozen patients treated with one particular disease with no control group, and that's produced as showing a benefit. So everybody's under difficulty here trying to keep up with the moving parts. So we've issued advice, and then we've had to issue revised advice and so on. So I would say that from our point of view, we advise people look at what our Department of Health is producing, our HSE, which is our public health executive, and the college, and everything else, take it with a pinch of salt. And it's useful for discussion, but it's not necessarily gospel. And I mean, the use of PPE, what was required for what kind of situation, that, was a huge issue for about nearly a month, and now has largely settled down. I think people have come to recognize the requirements, and I think people have a better handle on the nature of this disease and what to expect. You mentioned interviews. So we did our interviews face to face before this happened. I've done some interviews on Skype. It works okay. And in fact, the seminar we're producing next week on how to do video consultations, there is a certain lag in the video. And we're all familiar with this on Skype, in that you don't get quite the reaction you expect from people when you can see their face. So in one way, the telephone is better because you don't expect a reaction. When you are online and you expect a reaction, it's actually a little bit more difficult to get used to that. And there are techniques, I suppose, or at least you need to be aware of that. And for instance, given this talk, it's actually much more difficult when you're giving it to an audience and there's no reaction whatsoever and it's silent. And it's a little bit disconcerting to do that. You assume that behind all those names and little red dots, there are people carefully listening. But of course, that might be a false assumption. Indeed, it might be a false assumption even when they're in a lecture theatre in front of you.
Yes. Okay. Any question from the audience? No. Any question of here, the faculties? No. Okay. So.
Thank you, Professor Kearney.
Thank you very much.
Now introduce our next speaker, who is Professor Hoppa from Sweden, and he's going to talk to us about training opportunities and minimally invasive surgery diploma, why and how.
Do you see my slides?
Yes.
Is it okay? Then I will try to just is it better now? Is it full screen?
Yes.
Excellent. So good morning again under the second day of the webinar. Thank you for inviting me. It is a pleasure to join you, both the faculty team, but also the participants. I'm here under this title representing the EIS, the European Association of Endoscopic Surgery, being the chair of the Education and Training Committee. Presently, we are following some paths in terms of surgical education. And of course, that this COVID situation has changed everything. Now, I think that we are at the end of the panic wave. Now, until now, everything was closed. All our programs are cancelled, or all our fellows have left their duties from those centers they were appointed to, and they went home. This kind of blocking in time, I think, is just temporary. So slowly we are going back to what we were doing, but in what percent and in which way, nobody knows yet. So I'm going to present what we can offer in terms of surgical education and what the future, how the future will change or will make us adapt. We will see. But before that, I think that it's interesting to see what our younger colleagues think that's interesting in terms of surgical education. This is a paper published by a very well-known group in Canada that sent a survey to surgical residents in terms of laparoscopic simulation training. And 95% of all the participants believe that simulation training improved their laparoscopic skills. 92% said that all that they learned was transferable into the operating room. And in fact, this is our goal, that what we are teaching them can be applied in the operating room. 56% agreed that proficiency in a simulation curriculum should be mandatory before going into the operation room, and also that just 1 second. And also that this kind of workshops should be included inside the working hours, not on the residents' free time. I think that this is also important. Lack of free time, it is cited as the reason for underutilization of these facilities, training facilities that are present in a lot of hospitals, but most of them are underused. This is the reality. And I think that especially nowadays, when traveling for getting education is slower and more difficult, those facilities has to be used at their full capacity. What is interesting now is that most preferred simulation tool was the live animal model, followed by cadaveric tissue. Virtual reality simulators were among the least preferred, so just 25%. And 91% of all the participants in that survey thought that this kind of program has to be introduced in resident training protocols. Now, going back to my focus, what is our offer in terms of surgical education on EIS level? Because we are following some paths. The first path is our fellowship program. This was introduced 6 years ago. This is addressed to surgeons under the age of 40. It includes a fellowship, a 3-month fellowship in a well-known minimally invasive center across Europe, but also in USA. And this fellowship is entirely financed by EIS in form of €6,000 for 3 months, so about €2,000 per month. Normally, the call opens every year in March, in the mid of March, and it takes 1 month. This year, because of Corona, we started like 2 weeks later, and we pre-launched this period in the way that is just this weekend. This weekend is the closing part of the call. We are scoring and matching all the applications. We have 3 independent scorers that are blinded to each other. They are sending their numbers to the chair of the committee. If there are some issues, then clarification and consensus is reached, and matching is done by the chair, and after that it is approved by the committee members. So what I want to stress out is that this process is very objective and correct, and it is not based on personal preferences and things like this. And after that, those fellows are sent to the host institutions, are presented the CVs, and the host institutions are approving those. For example, last year we had 78 applications with 30 applications, so 30 applications more than previous year, from 5 continents: Europe, Asia, Africa, 1 for North America and 2 for South America, totally of 38 countries. This is the worldwide distribution. And those are the winning fellows. As you can see, Central and East Europe are very well represented here. And they chose, you will see that in the right column, those are the centers chosen by the fellows. Just one small comment related to COVID. 3 of our fellows that were during their fellowship, they went home now. They were sent home, and one from Armenia that was in Sevilla, he refused to go back home because he thought that it will take a shorter time, and now he's blocked in a rented apartment in Sevilla. So we will see that what are we going to do with him. So this is the fellowship program. Another path is our endorsed workshops. Endorsing workshops is a guarantee for the quality of the content. So we have a rather long list of workshops throughout the year. We will see that they are very well distributed inside Europe. Being a EIS member allows you to have a 10% discount and minimum €50 for every EIS member. This means that, for example, if you're attending a workshop in Eastern Europe, having a little bit cheaper prices, around 300, 350, with the €50 discount, then you can attend a very good quality workshop for just €300. Those workshops are very well balanced in the way that they have 50% theoretical presentations and 50% hands-on. For the basic laparoscopic skills, they include pelvic trainers and simulators. And for the advanced laparoscopic skills, all the workshops have living tissue hands-on meaning pigs or sheep models or cadaver. So hands-on is 50%. In terms of distribution inside Europe, as I told you, both categories, basic skills and advanced skills, are very well distributed around Europe. Our newest program is called EIS Forward. It was introduced just this year. In fact, we were ready to begin everything when Corona started. The program is meant to support the development of minimally invasive surgery in those regions needing such an initiative. For example, this year we took the countries from ex-Yugoslavia. We are selecting a group of 10 to 12 young surgeons that, after including in that program, they will return in their countries and in their home hospitals. EIS is entirely financing 3 workshops inside this program, 1 fellowship with 3 months in a minimal invasive center across Europe, and at the end of those two periods, workshops and the fellowship, comes proctoring period, meaning that the mentor is going into the fellow's hospital, operating and guiding the fellow a little bit. And it is thought that 1 cycle will be around 2 years. The selection criteria is surgeons under 40 years old, minimal invasive interested, important that they are coming from a center that, when back home, will allow the fellow to operate, and a center that has the necessary laparoscopic equipment, and of course English speaking. For the Congress, like all the other societies, we are offering also travel grants, and from this year, for the local society, for every 50 members, it is offered 1 travel grant and 1 pre-Congress course. So if a society, for example, has 100 members, that we are offering for free 2 places in a pre-Congress course. Unfortunately, this year, our Congress in Krakow is cancelled, and this is why, instead, for 1 pre-Congress course, we will offer 1 place in a EIS endorsed workshop, and I think that's a good idea. And last but not least, about the minimal invasive surgery diploma, this is an initiative that started for 3 years ago. It is meant as a collaboration between UEMS and EIS, and it came due to increased need of confirming the capacity of our surgeons in doing minimal invasive surgery. Until now, the exam was organized during the EIS Congress. It consists in a theoretical part, 100 questions, best answer out of 5, 100 questions during 2 hours, and normally this is organized Tuesday before the Congress. And the second part, the OSCE part, is the next day during the morning, consisting in 3 clinical cases and 1 hands-on exam on pelvic trainers. The diploma is awarded during the General Assembly, like a festivity, and EIS is offering a travel grant of 750 euros for 5 best scored exams, with the condition that the person is an EIS member, he or she is registered for the Congress, and this is to be paid after the Congress. So, like I said, this would be the 3rd year. Last year we had 18 applicants, just 17 were eligible. 18 applicants, it was double more than the year before, the first year. They came from 14 countries, 4 continents, and 40% were not EIS members before. This is the distribution, worldwide distribution. And this year, due to Corona, we postponed everything. Most likely, we will begin again next year during the World Congress in Barcelona. Like a take-home message, I would say that something that I'm telling also to my son, that from the living room couch, we will not achieve anything. So we have to be proactive, we have to try, we have to inspire from our mentors, we don't have to give up at all means. And to be honest with you, Professor Fingerhut is one of my living examples. So never give up. Ask your mentors, Professor Andreevich here, and of course that you can also contact us. We are contactable. We are in your reach, and please do not give up. Thank you.
Excellent, excellent talk. Thank you very much. Very instructive.
Doreen, any questions from the public, from the trainees? Max? Nobody asked? No? No, they're sleeping today. Charles?
We should ask about the requirements.
I was going to.
Is it possible to maybe in a few sentences tell us what are the overall requirements to apply for this exam in minimally invasive surgery?
Yeah.
So that the trainees can be aware of that.
Yeah. So there is a logbook, and in the logbook is very well balanced and offers different modalities to include yourself in order to be accepted, in the way that in some countries the surgeons are not allowed to do endoscopy. So if they are not allowed to do endoscopy, then they can compensate with a number of appendectomies or cholecystectomies. In other countries, for example, rectal cancer and colon cancer are divided. So most of the surgeons, for example, in Sweden, even inside the colorectal team, we are divided in rectal cancer, colon cancer. So it is rather difficult to achieve the necessary number for different surgeries. I would say that this is the same problem also when taking the European diploma for colorectal surgery. So in this, from this point of view, our logbook is more flexible, allowing the surgeon to go inside the frame of the logbook. So go on the uems.eu, minimal invasive surgery diploma, and the conditions are stated there. So it is the logbook, and it is about the CV, and everything is sent to the company that is in charge with taking in all the paperwork. After the eligibility is accepted, then the process is going further to the questions and to the hands-on. So it's nothing special. I would say that it's easy to be followed. Currently, we are. We have already launched our new EIS web page, and which is called Members Portal. Inside the Members Portal will be available a logbook for every member, in the way that every time when we are operating something, we can go inside our own logbook and register the numbers. And in this way, you have a clear view on what have you achieved, what is still to be achieved. Also, in terms of workshops, you are going inside the logbook, clicking there. I clicked one endorsed workshop. This gives me another extra points in order to be eligible for the exam. So the logbook is and our member portal is thought to be like a path from the beginning to the end point, and the end point is the diploma. So this is how we planned everything.
Dorin, thank you. Dorin is my boss in the EAS training committee, but we have. I would like to
No,
ask you.
I'm your friend in the
I
IAS.
asked this last time because especially a small country like Malta, here you have two generation of surgeons. Okay, a young laparoscopic surgeon who was trained fully trained, and an older laparoscopic surgeon who picked up tricks and tips and tricks from several people by doing short fellowships. So in Charles' time, previous coordinators managed to negotiate the European exam and Royal Colleges of Surgeon exam to be done by Maltese trainees.
Yeah.
Now, as you know, there's a lot of requirements, especially from the European exam, the number of cases, etc. We obviously lack that in Malta. And for UAMS, the general surgery exam, we had allowed, we have how to say, to compensate with certain cases. Like, for example, we do not have a massive number of total colectomies and certain minimally invasive surgeries.
Yeah.
Would it be possible maybe from in the next meeting that that our trainees who are eager to sit for that exam have some compensation from one operative skill to the other, maybe?
Definitely, I think that this is the point, because we cannot offer a diploma which can pass, which can go inside the frame all over Europe. It's just impossible. And being flexible and in the same time not giving up to the quality of the exam, I think that this is the balance that we should achieve. So also in Austria, vascular surgeons are not so many that are graduating every year. So they decided that it's not used to organize an exam in Austria, but taking the European exam. So I think that this is the way to go to close some agreements with different teams across Europe and going and following those agreements, but in a way that the quality is still high.
Yes, exactly.
I think that this is the way to go.
I always talk about this small place because we have a quality assurance towards the Royal Colleges. That is the main thing. But more and more people are shifting towards an European thing. But we need a bit more closer relation to the European
So
institution. That
the
is
diploma, our diploma is rather young. It's just 3 years old. It should have been 3 years old if this year it wasn't the corona problem. So the diploma is young, but judging by how we developed from 7 candidates to 18, and this year we had 25, in fact. So we are going up. Our mission is to keep the quality high and to keep the quality of the exam high, and to do in that way that we can go inside the frame for most of the countries inside Europe.
Possible to have, like, we have visits from the Royal Colleges every so often, so that they can see. Is it possible to have I don't know, a committee from the Europe which would probably come and see the standard?
Definitely, I would say that it is definitely possible. Absolutely, and I think that this is the way to go.
Thank you, Professor Poppa. That was truly informative. Unless there are questions from the audience, we'll move on to our next speaker. Yes, Mr. Andreevich will introduce.
And we will need you to remove to stop screen sharing, please.
Yeah, sorry. How should I do that?
You just press stop screen sharing. I learned yesterday.
Press, just a second. Stop share. Good.
Yes, stop share.
Excellent. Good. Perfect.
That's perfect. So I think now we have our star, okay, under whose patronage we're holding this webinar, Professor Abe Fingerhut. I don't think introduction is needed because our young doctors know him very well, all his affiliations and publications, and his work is very well known. And now I know that Professor Fingerhut was in forefront for observing and developing the guidance for the laparoscopic surgery in a COVID-19 situation. So, Prof, please go ahead.
Okay, thank you. Just have to find the sharing thing here. There we go.
What you say, Max?
Everything okay? You see my screen?
Okay.
Perfect.
Okay. First of all, thank you for the organization of such a meeting. And we're going to change gears a little bit from, let's say, the pure educational aspect to a more general aspect. And I hope maybe to answer some of the questions that were brought up by our first speaker, some of the interrogations that were brought up by our first speaker, Sean. Indeed, there has been so many questions that have been asked and raised and answers that were so confusing that I think it's time to really go back to basics and try to understand what's going on. I'm a little bit worried about the fact that because just of the COVID, things have changed so much in the literature and in the educational aspect of what we've been doing for the last 2 or 3 centuries. We've gone from laparoscopic surgery has its place, a well-known place, and then all of a sudden there was some sort of a fear that came out of the blue sky that was actually not founded on any scientific basis. We went from evidence-based surgery to the lack of evidence-based surgery, back to narrative-based surgery, and I agree with Sean. Everybody is confused. So let me try to straighten things out, if I can. Today, we all know that most of the healthcare authorities have been asked surgeons to cancel elective surgery, only perform surgery when absolutely necessary, either life-threatening or limb-threatening for vascular surgery, cancers that cannot wait. But more alarming, as Sean has pointed out, that some of the most well-known learned societies warned right from the beginning not to perform laparoscopic surgery. What happened? What happened to the laparoscopic surgery? Why did these surgeons in those societies decide that laparoscopic surgery all of a sudden was dangerous? Well, as Sean has pointed out, one of the major issues was the issues of aerosols. And aerosol is what? It's the consequence of pyrolysis of tissues when they attain the temperature of 100 degrees centigrade. The particles that are generated are different sizes according to the source of energy of the energy. Laser energy, for instance, giving the smallest and the hottest particles, while ultrasonic devices give rise to larger and a little bit cooler particles, but they're still over 100 degrees. And the consequences are that we have these particle concentrations that tend to increase also over the time of use. The longer you coagulate, the more particles you're going to generate. Seems very obvious. But what people do not realize, and I don't understand why, it's the same in open as is in laparoscopy. We create the same particles. We use the same energy. There's no difference in the aerosol that we do create. And there's no difference in what the particles are. There's a little bit of a difference in the dispersion. In open surgery, it's open by definition. So what you're doing is open to the air. It's open, it's going out of the body of the person into the operating room immediately. You can suck it out. You can use ventilation systems, but it is going from the source, the cautery, the laser, the electrocoagulation or the ultrasonic coagulation, and it's in the air. To the difference of laparoscopic surgery, where it can go out via ports, it can go out during instrument exchange or port displacement or withdrawal, or when you open the abdomen to retract the specimen, or when you have to convert. But we know that. Other than that, in laparoscopic surgery, the aerosol is contained in a theoretically closed system. So we have to be sure that it stays closed. That's all. We know there is a lot of procedures that create aerosols. And we know that it's our problem here now in laparoscopic surgery to look at them. So let's take a little bit look at what's going on. Just before that, however, as Sean has pointed out, from the beginning, no laparoscopy, and then society started to change their minds, whether it's in Australia, whether it's in Great Britain, where people have changed the wording, but no one has come out with a statement saying that there is actually no greater risk with laparoscopy than in laparotomy, as far as the surgical smoke issue is concerned. It's not a problem of laparoscopy versus laparotomy. We have a problem of aerosol. We have a problem of particles being in there. Well, let's take care of that problem, whether it's in laparoscopy or not. Sorry, let's go a little bit better. Let's go a little bit further. Now, we know the traditional advantages of laparoscopy that have been around for years. Everybody's publishing shorter hospital stay, fewer complications, less wound care. Well, now that we have the COVID issue, these advantages are really coming to the highlight. This is really something very important, because this is the way we're going to get rid of the need for hospital beds for other patients and for personnel. If everything works well, and it should, shorter hospital stay, fewer complications, less wound care, we're going to be very effective in the COVID area, where we need more beds and we need the personnel to take care of patients all the time. But how do we do that? I mean, what is the problem? The problem is we have to abide to rules. There are risks that we have to be aware of. And I cite a paper that we wrote in Annals of Surgery with Professor Zheng from Shanghai, that you see cited here on second position. There is a need to be aware of the dangers in order to avoid them. So that the best approach that we have today is to be able to take care of the patients with the knowledge of what's going on, adapted to the competence of the surgeon with one or the other approach. And of course, there is a need also to be time-consuming. The time-consuming issue is important, because operating room time is very critical today. But that doesn't mean we have to revert back to laparotomy. Once again, it's about the awareness that the potential dangers are there, and we have to know how to avoid them. It's the surgeon and not the surgery that is being considered here, that's implicated. Those who have prone laparotomy and the recommendations are not the tenors of laparoscopic surgery. We all know that. We have to be very conscious of that. Well, I'm going to show you, I think, I'm going to tell you, I'm not show you. I'm going to tell you that there's no risk. I've told it already. I'm going to insist on it again and again. But before I do that, I want to cite a very famous statistician, Douglas Altman. Douglas Altman came up with a statement: absence of evidence is not evidence of absence. Those who have insisted, that have assisted some of the courses that I teach, know this slide. I've talked about it many, many times. It's not because we don't know something that something does not exist. It's not because we don't know if there's a risk that risk does not exist. And talking about COVID, it's not because we have any proof, that we don't have any proof that it does exist, that it does not exist. Okay? A lot of words. Take them carefully. Listen to them carefully. This is why we have to have an attitude of a precautionary attitude. And I'll talk about that at the end. So let's go back to my problem. We know that COVID-2 has been detected in blood. It's been found in stools. It's been found in peritoneal fluid. We've heard about that. Not one study, but 2 studies. And these findings imply, I'm sorry, my slide didn't work, that gastrointestinal surgeons operating on the bowel have to be conscious of this. And when they use energy-driven devices for dissection, for hemostasis, we have to be aware of the fact that there is a potential risk of it containing SARS-CoV-2 particles. Let me go. So, once again, it's not the smoke problem that we have to worry about. The smoke problem is even probably worse in open surgery. There's not one scrap of evidence that proves that surgical smoke created in laparoscopy is more dangerous than that is in the same patient using the same energy in laparotomy. No one has ever been able to isolate the virus in the aerosol. The only experiments that we know about is from Holland, and that was in a drum, an artificial drum. We don't even know if the particles that were put into there are viable. And that's what we have to worry about. It's not because we have particles there that we know that they're viable and they can do some damage. But once again, to the contrary of laparotomy, surgical smoke created during laparoscopy is contained within a closed abdominal cavity and as such does not diffuse into the room while you're operating. However, we have to be very careful now to make sure that it doesn't escape. So there are some precautions that are necessary. And once again, the paper that we wrote with Singh in Annals of Surgery and a recent paper that was accepted for surgical endoscopy with Yoav Mintz highlight these. Let me just take a few minutes to talk about this paper that has been accepted for publication but has not been published yet. It's all about the risk of transmission by surgical smoke during laparoscopy. And you can see from the title that we say it may be even lower than laparotomy. It's a narrative review. It's not a systematic review because, as many people have pointed out, there's very little evidence around. So we cannot do an evidence-based, this is a narrative-based study. Of course, we can't do anything better for the time being. And as I say, the conclusions are as long as laparoscopy is not indicated for a respiratory problem or for other problems that I'm not going to deal with now, we believe that the surgical approach to laparoscopy is actually safer for the operating team because of the effective control and evacuation that can be performed. We do need more evidence, But for the time being, we can make some recommendations. These are, don't use any procedure that is like laparotomy, for instance, hand-assisted laparoscopy, where you have a communication or a possible communication between the operating room and the cavity. Be very careful when you're dealing with the intestinal tube. Seal off your intestines as much as possible. Make sure that there's no spillage. Make sure that there's abundant lavage and within the closed cavity. Make sure that your trocars are never opened inadvertently. Make sure that the stopcocks are closed. You can even seal them with a protective cap. Don't vent with your trocars to get rid of the smoke. Use a ventilation system, an internal ventilation system. We have that. The machines today all are capable of ventilating the smoke. You don't need to open the trocars to vent. Be very careful when you insert and withdraw your instruments. Swiftly, precisely, parallel to the trocar shaft. Don't enforce any torque on your trocars. Make sure that before you do any maneuver, whether it's for the end of the operation, whether it's for specimen retrieval or conversion, make sure that everything is closed and that the entire CO2 pulmoperitoneum has been evacuated. Also, check for air tightness of your trocars before each operation. Probably disposable trocars should be preferred over reusables. Make sure that we have a good evacuation system, and I'll talk about that in just a few minutes. Sorry. This was the other paper that we did with the EAES, and it was, one of the first papers to talk about an easy, low-cost, easily assembled, effective measure to evacuate smoke during the evacuation part of what we're talking about, getting rid of the pulmoperitoneum. It's one of the examples. There's many examples. There's many systems out there today. I'm not saying this is the best, but it was the first to be published to draw attention to this very, very fact. So going back to the question, is there a problem between laparoscopy or laparotomy for surgery today? I would like to remind you of the haunt that we had many years ago when we started doing laparoscopy for cancer. There was a flood of papers saying, oh, danger, danger, port site metastasis due to laparoscopy. Time went by, people realized that there were explanations, and what was the most frequent explanation? It was the surgeon, not the surgery, that was responsible. You have to abide to rules. Laparoscopy has to have rules, and we have to abide to them. We don't want to throw the baby out with the bathwater. We have to be aware of the hazards and be responsible. Ourselves, surgeons, not the politicians. So let's go back to our question. We have to be conscious of the fact that laparoscopy has its advantages, and it has not only advantages for the patient, but also in the COVID era, it has advantages for the operating staff and for hospitals. Let's take care of that. Let's take advantage of that. And in the post-COVID era, the same thing. There is no reason to throw the baby out with the bathwater. Thank you for your attention.
May I ask you, would you give us any suggestion about pressures to use during the procedure?
Okay, good question. People have said, once again, this is narrative-based, it's not evidence-based, that you should use the lowest pressure possible. There are two problems with the pressure in laparoscopy, especially in the COVID area, perhaps if we talk about the risk of aerosol. We want to use the lowest pressure possible with the idea that theoretically that higher pressure has two consequences. The main consequence being the pressure against the diaphragm. And if we have a high pressure against the diaphragm, we might have a problem, or at least reduce, we know we reduce the compliance of the lung during laparoscopy. With a pressure of 15 millimeters of mercury, the compliance is reduced about 30%. So if we reduce it to 10 and we can still see, there's not a problem of visibility, we will reduce the effect of pneumoperitoneum on the pulmonary compliance. That's number one. The other thing is that if we have a lower pressure, we might have there's another problem with the laparoscopic surgery, especially in colorectal surgery, is the use of Trendelenburg. Now, when we use a Trendelenburg, obviously everything is on the diaphragm once again, and this may be. It's been reported that the Trendelenburg does have an effect on pulmonary compliance, but has a very little effect. There's a lot of studies now that have come out and sort of dispelled the fear that Trendelenburg is dangerous for that matter. So low pressure, as low as possible without impeding the visibility, and also to try to decrease the effect on the pulmonary function. 10, let's say, try to aim at 10.
Thank you.
You see, this is a fantastic talk and a very well explained. And as big surgeons, I think the people will actually accept all this precaution and this scientific thing. But especially in local setting, when we live in a lot of how to say this the union how to say era, that like I would probably say like a communist union era where unions have a lot of say, it would be probably very difficult to persuade
I can come talk to them anytime you want.
Nurses and the other things. So I don't know whether we should have an open talk with them and put this
Of course.
die, because they think that all will die as soon as you put the scope inside. The union thinks that we will kill them all.
I can come and speak to them anytime you want.
Okay. Hi, Joe.
Pleasure.
Any questions?
Morning, Joe.
From the administrative point of view, the issues are a bit more complex than that. The issues are to do with litigation, and litigation comes from a scrub nurse participating with you for a laparoscopic cholecystectomy. She gets COVID a week later and ends up in ITU and dies. Imagine that scenario, okay? Now, whether that scrub nurse got the COVID from the supermarket or from the changing room or from the operating theater, it's impossible to determine. However, the word out there is that there are questions about the safety of laparoscopy. Now, listening to Abe, I am convincing myself more and more that laparoscopy is not unsafe, okay? However,
it's not more unsafe than laparoscopy.
Yeah,
Safer,
of course. I'm in line with what you've just said, Abe. And as I said yesterday, in Malta, our viral load is very low, not to say infinitesimal, but it's very low. So that's why I am, a bit more clear in my head that there should not be an issue with laparoscopy. However, the people out there, and when I say the people, I mean nurses, administrators, families, lawyers, of course, they surely know that there was a question mark about the safety of laparoscopy. So
and that's the fault of, yeah, and that's really the fault of the learned societies that went overboard.
Agreed. But now, when I raised my concerns about laparoscopy, it was mainly from this administrative perspective, which is sad, but surgeons are administrators as well, and vice versa. But, as time goes by, over the past 2 weeks, I've become more and more receptive to the idea that we should, restart doing what we used to do based on evidence, as I said, So I have no issue with that. My only issue is with what if that scenario.
Yes.
As you know, our infection control specialists and our top administrators have now sort of come round this, and we're all, I think, of one mind now.
Yeah.
It's not.
Well, I think, yeah, I understand your problem, and I'm very sympathetic with the issue, because this is the whole issue that's been around since the beginning of the COVID. This is the issue that I have to dealt with world around, with the beginning of the COVID epidemic and then pandemic. I think there's an educational issue that has to be done, not only for surgeons, but also for the medical staff and also for the administrative staff.
Exactly.
And one of the pilgrims' marches and pilgrims' staff that I'm going to take up in the near future, and I've already started, is going to be the education of the surgical staff, not only the surgeons, but the surgical staff, the operating room staff, and perhaps also the administrative staffs of hospitals. I think really you've hit the nail on the head. This is where we have to concentrate our efforts in the near future now.
Peja, can I pose a comment, Peja?
Of course.
I think I want to clarify that laparoscopy has been decided that it is safe in Malta by our infection control people, because we have a few cases of COVID in the community, not because they are convinced that the technique is safe. And I think those are two very different concepts. Professor Abe mentioned that there is a viremia in COVID, so there is actually virus within the blood. Now, if you are doing a laparoscopy,
okay, yeah, go ahead.
If you're doing a laparoscopy and the port moves and some gas escapes around the port and it carries some blood with it in an aerosol, how can you convince me that that is safe?
I cannot convince you that there is no risk. But you have to understand, I'm sorry, we have to go back to basics. We have to go back to epidemiology.
But why should I?
Because one person, it's not because one person or even 6 people that we found had viruses in their blood, that everybody has viruses in their blood, number one. Second of all, that once an aerosol is created with 100 degrees centigrade, don't forget that. I'm not so sure viruses can live through 100, but that's never been proven one way or another. But let's say that the viral particles are there and have been found. Nothing has ever been proven that those particles are viable.
No, I'm not saying an aerosol of
or blood for that matter. Same thing. It's the same problem.
I'm saying an aerosol that is produced around a leaking port, and it carries blood particles with it containing the virus. Those are infective. And in open surgery, we create an aerosol when we coagulate the tissues at 100 degrees. So I agree with you, they're probably not viable. But we do not create an aerosol of...
Sure we do. Of course we do. Of course we do. There's no difference. The only difference is that it goes out with a higher pressure, that's all. But it's the same aerosol. It's exactly the same aerosol. Exactly the same concentration.
There's
absolutely
a difference
no
between
difference.
an aerosol and droplets in the size. Droplets are contained by a normal surgical mask. An aerosol is only contained by a 95, special mask. So I think if we're going to do laparoscopy, everybody in the theatre has to wear the full PFE and not just a surgical mask.
Okay, then do it. Then do it.
But there are problems.
If you think that's a problem, then I have no problems with that. Do it.
Because you cannot have a whole theatre list, a whole day list wearing those masks. And also there are problems with resources. We need those masks for when we have patients who are infected. So I am still a bit skeptical about reintroducing.
Okay, you brought up another problem. And let me tell you something. Our president of France went to a hospital yesterday. He was very happy to say, oh, the healthcare workers, you've done such a great job. We're going to give you a special prime, 1,500 euros for the excellent work you've been doing. He almost got killed. People are not interested in a prime. They want budgets to change. They want the healthcare system to change. And it's our responsibility, all of you looking at me and hearing and listening to me, to go to our healthcare administrations and tell them, yes, we have a problem. And if you want it to be protected, if you want the patients to be protected, we need the budget to do it. I don't understand the argument of budgets anymore. I hope people have understood that the budget restraints that were around before COVID were not the most important reason, but one of the main reasons why we got caught unprotected.
Yes, but there's a difference between having the money to buy the protective equipment and being able to source it. We have the money, but we find it difficult to buy.
Well, we have to find a way of doing it. Where there's a will, there's a solution.
Yes, we got 8 plane loads of equipment from China. 8 plane loads.
Yeah.
Each one was 10 tons.
Right.
But still, we cannot waste it.
Gordon.
And my argument, if you can do an operation open and laparoscopically, why should we use all this extra PFEs when we can do it not that differently open? This is my argument.
Because you think there's an increased risk with laparoscopy, which is not true. The risk is exactly the same. You need the same PPGs. You need the same.
No, for laparotomy, we don't need the full PFEs. You can use surgical masks.
I'm sorry, I disagree.
Mr. Gawadingli, thank you very much for your opinion. We have a few questions from the audience. May I kindly ask Chris Kamenzuli to ask us his question?
Thank you, Professor, for your presentation. Very practical, especially the extraction system you have showed us, which was something that I was speaking to Mr. Abela, I think 1 or 2 days ago, about very similar system. My question was about exactly what we were talking about with Mr. Kawadingli, the type of PPEs that we're starting to do laparoscopy now. And I understand what you presented, that sort of the risk should be the same theoretically. But what do you do in your practice? Are you wearing N95 or FFP3 masks for every procedure, and specifically for laparoscopic procedures? What are you wearing? Thank you.
We have different equipment today. During the era, and I can talk about what. Let me talk about the experience of China. I'm very close with Professor Zhang in Shanghai, and he sent me many pictures of what they did during the COVID scare, let's say, where they were fully equipped with visors, with they looked like people walking on the moon. Will this protection stand and be required for the time being? People are looking at what we should do today. Is it enough to test every patient that is going to go to the operating room to see if he's COVID positive or possibly COVID positive before we decide on what type of equipment we should be using? These are things that we have to look at and perhaps come to some conclusions. And I know there are many people that are looking at these issues today, and will hopefully in the next couple of weeks we'll come out with sort of recommendations on what should be done according to the COVID status of the patient before you decide what type of PPE you should be using. Very good question. I thank you very much.
Thank you all. We have another two questions, but I think we have answered them. I mean, you answered them. One is from Neville about the medical legal issue, which I think Mr. Abela already mentioned, and the other one is the recommendation of evidence, but that was in your talk. Unfortunately, we're running very low. I mean, if you want a brief question, because we have another two talks, maybe Doreen. So I think.
Let me just let me. If there's anybody that has any questions that they want to ask me, please use the email, and I'll be more than willing to answer by email.
You can ask the chat on the chat.
Right.
Okay.
I wanted to comment on something that I think it's really important from Professor Fingerhut's presentation, and this is that, like, really strange, our surgical practice changed without any clear explanation. And I totally agree with that. And this is because of this panic that was influencing all the world. So if we divide our patients in COVID negative and COVID positive, then, Professor, all those COVID negative shouldn't influence our strategy. Do you agree with me?
That's one possible way of looking things. It's not very practical for the time being, but it's one possible.
I'm just saying, if they are negative.
But I disagree. I disagree on that, Dorian, because our tests are at best 70% accurate.
I agree.
That's
but
the problem.
On the other hand, I agree, but on the other hand, we cannot just do stomas to all the patients because they have the.
We're talking about. I thought we were talking about PPE. Sorry, and I agree with Gordon, if I may say. I agree with Gordon that we should operate, I think, every patient wearing full PPEs, because our preoperative tests are not 100% sensitive. So
I wasn't speaking about the equipment. I was thinking about the technical issues, surgical technique. So if the patient is COVID negative without any symptoms, CT, normal lungs, would you operate, Professor Fingerhut, for example, some kind of colon cancer with anastomosis, laparoscopic, without any other issues? Is it correct?
I would do. It's not. The problem is, once again, not whether he's COVID positive or not. Is whether that he has, as you pointed out, does he have any pulmonary problem? Is there going to be any problem afterwards for that, which we don't know about?
So if we don't any signs of some kind
you're
of
asking
COVID.
If I would do it, I say yes, I would do it.
Good. On the other hand, if we have COVID positive in a good condition, are you doing stoma for a colon?
I will not change my attitude because of the COVID status per se. It depends on how well the patient is tolerating surgery, laparoscopy, for instance, or surgery in general. I mean, even laparotomy could have a problem.
Precisely.
Okay? You know, there's not much evidence out yet, but there is some narrative evidence that I want to share with you. A paper by Lee, from China, who operated. They were 37 patients in that series. 7 of those patients had developed post-operatively pulmonary problems related to COVID and died. None of these patients, and 7 patients also underwent laparoscopy out of the 37. None of the 7 patients that died after laparoscopy. They all died after laparotomy. So this is, of course, narrative. It's circumstantial, but it is just one example that you don't. Once again, don't throw the baby out with the baby water.
But Professor Fingerhood, if you have a COVID positive, then would you do like the quickest of the techniques? Quick in, quick out, or?
Okay, good question.
In a patient with good condition.
Good question. And then you're raising another issue, that is, if you have to be very quick with laparoscopy. If you're better with laparoscopy, then do it laparoscopically. If you're better with laparotomy, then maybe it's better to do it quicker, but not for the reasons that we're talking about. We're talking about a different reason now. You're talking about a reason that you want the operation to last as short as possible. If you think that's important, do it the quickest way you know how to do it.
Do you have some numbers in terms of length of intubation?
We are short of time, unfortunately.
Good.
Very much, Professor Fingerhood. Your talk led to a very interesting discussion. And we're going to hear a bit more about this. And I ask Mr. Andreevich to introduce our next speaker.
Yes.
Okay. Thank you for your attention.
Can you just stop screen share? Okay. So you will probably continue arguing on the same thing. There is a Professor Ronald Cahill from Ireland, from UCD in Dublin, who is going to give us a very, very interesting overview about the laparoscopy and the problem with aerosolization and the air in the abdomen, as well as approach to the mesocolon. Ronan?
Hi, Pedja. How are you doing?
Okay, I'm very sorry, but as you know, how to say, discussion got a bit heated and we could not interfere. We tried, Charles and myself and the audio engineer to intervene, but
it's a fantastic discussion, and it's a fantastic forum, actually. This is really great that we have some time to talk across different countries. You're to be congratulated. Fantastic. I really enjoyed that discussion. Can you see my screen?
Yes.
Okay, so hopefully we can.
Yes. Okay.
Okay. So I agree with everything Professor Fingerhood said a month ago. I'm not so sure now. And in talking through this, I'm not going to try and say I know all the answers, but I'd love to hear your thoughts about this and everyone's thoughts about this, because I think it's terribly important. But a month ago, 6 weeks ago, when those guidance to stop laparoscopy came out, I wrote to the College of Surgeons in Ireland and England and said, this is crazy. Don't do this. Don't abandon minimally invasive operations. Abandon 30 years of surgical advancement, because there's no evidence to it. And the guidelines have softened a little bit, but it's interesting to me that we talk about smoke all the time. And I don't think that's really getting to the fundamental issue we're talking about. The EAS and SAGES guidelines have been really good. And on Thursday, I did a laparoscopic anterior resection on a man with a sigmoid cancer stuck to the back of the bladder, and took about 3.5 hours. And this was my mask at the end of it. There's blood on it. And I think most people who wear glasses in cases will know that there's splatter. Now, this has nothing to do with smoke. There's sometimes splatter in operations. When it comes to COVID-19, we know it's spread in aerosols, in gas, and the particles may be airborne, so they may not necessarily need to be attached to droplets or micro droplets. But if we can't see this stuff, we can't do much about it, and it's very difficult for people to know what to do. I guess it's easiest for us to know what to do with things that we can see. one of the things we've been looking at is this aerosol box. Do you know the idea that if, for people doing airway intervention, the anaesthetist, you might put a Perspex box over the head of the patient so that the cough doesn't go everywhere into the room. But when we look at one of these Perspex boxes, this is the New England Journal of Medicine box, and we put Jeffrey, your colleague, into the box, it leaks. It leaks gas into the operating room. And I think we need to think about our laparoscopic practices a little more broadly than smoke evacuation. Because in lots of the papers and the guidance we sort of see, they talk about aerosols, and then the next thing it's smoke, and the next thing is smoke extractors. And we kind of conflate smoke with plume and vapor and aerosol and splatter and vortex. And all these things have different dictionary definitions, a bit different in the US compared to Europe, but they're all terms of concepts. And the concern, of course, is that pneumoperitoneum will disrupt the peritoneal surface. You're injecting gas in at pressure, and it disrupts the mesothelium. I agree the port site metastasis story was clinically irrelevant, but it did show us that actually putting gas in does circulate cells in the abdomen. And we know that COVID-19 has been in the airway, blood, and stool, and lots of our operations, of course, cause some bleeding, and they're clean contaminated into the bowel, and there is some particles in the peritoneal fluid. Now, I'm not trying to suggest that this means infection, but we need to be careful of this. And if we think about what we know about pneumoperitoneums, it takes about 3 to 5 liters of carbon dioxide to make a pneumoperitoneum. That's, if you look at your system, that's what gas goes in to cause the working space. But if you look at your system at the end of the case, maybe 3 or 4 hours, we've used 300 to 500 liters of carbon dioxide. Now, the robot uses slightly more. In bariatric cases, it's even more. But our solution to this gas use has been to increase the pressure, bring in the aerosol, go to high flow. But we know we need 200 to 400 mils per minute to maintain that working space. Now, some of it is absorbed into the bloodstream, and that's the anaesthetist manages the ventilation to move it out. That's only about 10% of the gas that we're using. And sure, if we're suctioning, we can use quite a lot, up to 25 liters per minute. But we only suction for, a couple of seconds at a time, and a couple of minutes at a time. And there's been lots of work done looking at the greenhouse effects of surgery. And we know that that the carbon dioxide particulate parts per million rises in the operating room during operations. If minimally invasive surgery in the US was a country, it would be in the top 100 carbon dioxide emitting countries in the world. The key question, though, is this filtered? Is this controllable? Are we able to put this carbon dioxide through filters, ultra particulate barofilters, or is it leaking into the air, carrying whatever might be around in it? And the nursing organization has been very clear about this for years, that there is it's like passive smoking, standing in an operating room all year, all day. We just maybe haven't been very interested in it. So we tried to look at this, because you can argue everything, and if you do a systematic review of the literature, it's not really there. And I think we've been a little complacent about the issues of gas leaks, and if we just look to what we already know, it doesn't often generate new data. This is Jeffrey, who's been a fantastic addition. He came just after Patrick's Day, and he's really gotten stuck in clinically and academically. And what we're talking about here is sclerin technology. Now, this is rather sort of old style physics. 2 parabolic mirrors that set up a parallel beam of light, and we're looking at optical densities. We're looking to see changes in the air density. Carbon dioxide is a different density to oxygen, and of course, it's warmed in the person and it's humidified in the person. So you are able to detect it sensitively different to room air using this sort of optical imaging system with a high speed camera. These are 10,000 frame per second type cameras, and that's where we made that cough video and the aerosol box video. But we're surgeons, so we've got this in place to do this during surgery, and to see, can we look to see some of the air leaks that are happening. And it turns out we can. So this is sparing during an operation. We've mostly been doing this in cadaveric work in pigs, but we're soon to do it in human cases. And we think there's a different way to think about leaks than maybe has been sort of clearly stated before. But this is work in progress. It needs to make sense among all of us. I'm really happy to hear people's views or to try and make sense of this. I mean, I think so. We know that deliberate venting of the pneumoperitoneum is bad practice. We've all tended to do it, but certainly you blow gas out deliberately to clear smoke inside. You shouldn't take your ports out with the pneumoperitoneum in place. You get this volcano of gas coming out to it. So that's habitual practice, and that should be addressed through training. Although all of us have been trained, and all of us sometimes do these things. The bigger problem, I think, though, is this sort of inadvertent leaks. In the guidelines, you kind of say, well, make your incisions snug and put the ports in exactly. It's really hard to do that, actually. And even if they start snug, they may not end snug, particularly in cases with lots of rotational movements of the trocars, and the elasticity of the tissue means that you can leak around your trocars continuously during the case. And you may not even notice it, particularly if you have an effective insufflation system, because mostly we're looking at the screen and not at the monitors. But that's part of the reason why your gas consumption is going up into hundreds of litres over the case. Now, what we did in this is we didn't deliberately make leaks. When we looked to try and find solutions, we did deliberately make leaks, and that's the leak model. But this is actually using senior surgeons placing ports, and we're looking to see. We used three ports from 3 different companies, and we repeated these three times. And we're just looking. We have to be able to see stuff and then quantify it before we can hope to address the problem to it. And we're not talking about particles here. These are air vortexes. They'll carry particles. You see that they're it's rather local to the area of the port. It does go up into the room. What's happening there is the carbon dioxide is diluting in the room air, and you stop seeing it. But the turbulent flow it sets up continues on. And if you had a splatter board at the top of the room, a white bit of paper over your operation, you would see moisture and blood particles up on this. So that's at the abdominal wall level. Slight imperfection of the putting in the port. I mean, we talk about ports 5 millimeter, 10 millimeter. That's the internal diameter. The external diameter is a bit different, and it can vary in a 5 millimeter port from 6 to maybe 8.2 millimeters, depending on if it's fluted or corrugated or thicknesses between the different. So, but we don't really use a precise mathematical incision of the formula. We just make a 1 centimeter incision and place it in. So there is gas leaks that happen at that level to it, and we think these are inadvertent. Every time you put an obturator in or out of a trocar, gas leaks. Every time you reposition it, at the start of the case when you're putting them in, the trocar is holding the leaflets open, and gas is leaking out at that time. And in fact, if you listen, I mean, if I just played you the audio of an operation, we're all quite familiar with that little psst, psst that tends to happen when we put obturators and gas in. This is a Hassan port by Applied, and I don't know who uses Applied. We tend to. The obturator is hollow, and it has holes in it. I don't know why it does, but it does, and it tends to leak gas out through the middle. And then you see these holes here. These are out there. Now, of course, you shouldn't be having a pneumoperitoneum when you put in your first Hassan port, but for every port afterwards, you do. And the case we did on Thursday, twice the ports came out as we were exchanging instruments, and during the operation, and we needed to place them back in again. Optical trocars, of course, that's the whole purpose of how they work. You attach the carbon dioxide and you try and put it through the abdominal wall. So of course it blows gas. Now, I guess mostly that's outside the abdominal wall until you get through the layers and in. The third category we think of is inbuilt leaks. So every time you put the instrument in or out, you do get this little jet aerosol that happens in and out of the case. This is putting an instrument in, and I'll show you next putting the instrument out. Now this gets worse when the valves leak, and we've seen gas leaks happening within about sometimes as quickly as three or four instruments in insertions and exertions. I mean, these are commoditized items, and you know they can be imperfect. There can be these little gas leaks happening to it, and that's particularly that little noise every time you put your instrument in. The robot's interesting too, because the robot instruments are full of levers and full of hollow space, and robotic gas consumption tends to be higher than laparoscopic, and that's why lots of people use the ConMed device to kind of have high sufflation. That's always been our problem. If the pneumoperitoneum is variable, we tend to turn up the gas to compensate it. But if you look at this is a Da Vinci robotic scissors, and this is a bit of a homemade experiment. You can repeat this at home. If we tie a glove around the robot side of the instrument and apply gentle positive pressure to the other side, you see that it's very gas permeable. This isn't blowing into it like a trumpet. It's just gently blowing up the instrument. And I'll show you next where the gas is leaking from. It leaks back up through it. It's a two-way open system. If you put the head of the instrument under water, and again just gently blow. This is a clean instrument. You'll see lots of bubbles coming out. Mostly where of course where it's been attached. So some of these holes are going to be blocked by the instrument insertion into the robotic system, but they're not hermetic seals. That's not what it's being designed for. And definitely gas can move through these areas. Now, so I mean, how can we deal with it? Smoke extraction is definitely part of the problem, but I agree with all the points Professor Fingerhood has made about it being hot, and it's no likely to be different in open operations. And you have the opportunity that you can see the smoke, and then you can know to suck it out, and you can put it through a particulate filter and increase the safety of the room. We're always going to be really good at things we can see and know about and have tools for. Now, I mean, you know, can you put an enclosure around it? Sure, I mean, but it's a bit stupid, isn't it? You know, it's going to restrict where you put your ports. It's not going to be very easy to work with, you know, that's just sort of that's a theoretical experimental kind of idea to it. Sorry, now if I can, I think I've made a mistake in the slide. Yeah, if I come up here, where was I? So, I mean, I don't know if this could work. I mean, what you need is stuff that's built into trocars. This has to be something that's in the equipment. But maybe this sort of O-ring concept, you know, gas suction at the abdominal wall level and to the top. I mean, maybe that's not so ridiculous. Of course, you want it internalized into the trocars, but here you have a abdominal wall leak. Now, this is a leak model. We did make the incision a bit big. We wanted to have a decent leak, but there's a ring. There's a ring being placed at the abdominal wall here attached to a suction. That's with the vacuum off, and then if you turn it on, the leak goes away. Of course, it does. I mean, it's just vacuum. It's just placing suction where it might be. Here's a 2-port model. These are leaking through the leaflets. We damaged the leaflets here to make sure we could get a good leak. And you'll see this one has the ring vacuum at the top, and this one doesn't. So this should stop, and this one should keep going. So it stops, and the vapor here has been pulled a bit in towards the vacuum here. I mean, there's a few things to do to make that practical or useful, but really, if you are thinking, I mean, this is what the CDC in the US's approach is. That, you know, if you have a hierarchy of hazard controls model, really your engineering controls trump your administrative control. Just telling people to do something better or beating up on them because they didn't do it right is a high risk strategy to do, and it's prone to error. Putting PPE on everyone is, of course, an admission that you can't really do anything about the fundamental problem, and you have to set up a closed circuit around the person themselves. But until you get to elimination, whether that's through effective drug treatment or vaccination for COVID-19, we need to be better at putting in sort of inbuilt engineering controls. And I think the problem we haven't done this already is just that we've been complacent over carbon dioxide. It's cheap, it's easily available. The porters can bring in another canister of gas easily to attach it to a stacks. There's 1,200 litres of carbon dioxide in those canisters. I mean, there's sort of, the law of the instrument, if all you have is a hammer, the whole world looks like a nail. If we have smoke extractors. We know this is very good. We know we can see smoke, but it's only probably a proportion of the problem. And the danger is, of course, that if you think you're doing everything perfectly, you might be a little complacent with other things because we're assuming we're in control of all those things. Masks are kind of interesting too. They're variable, of course, depending on how you put on them, the size of your face, have they a beard or not a beard. And we're mostly looking here at masks to protect the patient from the surgeon, not protecting the surgeon from the patient. And that's where I agree with, I think, Gordon's point about wearing gear. We've been trying to look at the College of Surgeons in Ireland about, is this sort of, surgeons in scuba gear, is that, can you actually work like that? Is it acceptable? Is it tolerable? And most particularly in simulation settings when communication is terribly important. Can you collaborate and teamwork in these type of gears? I think you can. It's not perfect. You can see the tubing out the back. You have to be mindful spatially. But I think if all we're going to talk about is smoke extraction and restart laparoscopic surgery in that way, it's kind of, without trying to twist anyone's tail too much, it's kind of guidance for the canary in the coal mine. I mean, if that works, we can restart safely, but just depending on smoke extraction and surgical technique. I think it's going to be really because we very good PPE, or because the virus isn't infectious at all in the peritoneum in this way. Because I think it just seems unlikely that unless we see the totality of the problem of aerosolization, just focusing on one component is really going to be, part of the solution, but not the whole solution. Now, that's all I'm going to say. Really, really interested to hear other people's thoughts about what does this mean.
Fantastic talk, just fantastic. I'm really very appreciative of that. I would, first of all, my first remark is that what is missing, Roman, is that we need the same images with laparotomy. I'm almost sure that it's the same problem with laparotomy. You've said that, but we need to see the images because people are going to go away just looking at the images of laparoscopy and they're going to get a false impression. But I take your point very positively. I'm not criticizing at all. The other thing is that you've pointed out something that's absolutely fantastic to think about is that we're only looking at one issue, one part of the issue, the aerosol. And obviously, you've really hit, once again, you've hit the nail with the hammer. We have to look at other systems. We have to look at our conception of what PPE should really be, or are we looking at protecting the wound? Are we looking at protecting the patient? Are we looking at protecting the operating room altogether? So I congratulate you. You've done a fantastic a job of opening our eyes to the aspect of the problem that we have to deal with. I really thank you very much.
Well, look, that's really, really kind. But I mean, it's only the first step of it. The solutions are need lots of people to kind of help about it. So laparotomy, I mean, at laparotomy, the risk is splatter, which is a technical term, and cautery. But we're not blowing the carbon dioxide in and out. And that's kind of pains me to say it, but that there is that difference between it. Now, if you're looking at kind of, cautery at laparotomy, we did look at that in one case. It's disappointingly little, actually. You don't see a lot of smoke coming out. I was hoping there'd be this bonfire appearance to it, but we need to look a bit more. We are getting a very sensitive carbon dioxide camera, which they use in industry to look at gas leaks. So we want to spend the next week or so going around different operations to try and see what we can see in all these different aspects to it. But, the room ventilation probably is why we don't keel over from carbon dioxide narcosis. But of course, as the particles are going between the site and the ventilator, there is that kind of risk to it. But yeah, I think if we can illustrate the problem, I think there's very many smart people who can maybe start to address the problem. And what you're looking for, low-cost solutions that can be put everywhere into the world and become fundamentally part of it. Because the other risk is the precedent now is to close laparoscopy the first challenge. And if there's a second wave of COVID, if there is another type of pandemic, maybe every 5 or 6 years, we're always going to be the first out. And I think this is our Achilles heel, our casual approach to carbon dioxide in the room. It's very few papers even mention how much carbon dioxide is being used. We talk about pressure, not volumes.
Fantastic.
Very, very good. Very, very good remarks. We just have to congratulate you on that. We're looking forward to the future, what you're going to come out with, and I'm personally very interested in collaborating as much as possible with you on this issue.
Super. Any ideas you have about how to kind of just be smarter? Pecha, you're thinking about a port. It's almost like back to 1990s, maybe thinking about
absolutely.
We have to. Charles and myself have done some work. Hopefully next week we'll be able to show you something. I told you and Abe probably some kind of hopefully a prototype. I really don't know how it's going to work. That's why I kept my mouth shut. I would like first to see what's going to happen, and then I would love if we can join the forces, of course.
Thank you, Ronan, for that fantastic talk, and thank you for sharing with us all this innovation. And do you have any questions from the audience?
No, they're all shocked, I think.
It was overwhelming. Maybe then we can go on.
I would like to congratulate you on another thing as well. It probably took a lot of thought and a lot of practice to put Jeffrey in a box because he's quite a big man.
We kept him there.
We're not going to ask how it affected the pressure and
or whether you managed to take him out of the box.
Jeffrey's been fantastic. He's full of ideas. It's not easy to come to a different country. But what we're seeing kind of interesting in the hospital, I wonder what other people's experience, there is lots of people with ideas. It's quite hard to get them done in the hospital. When you call everyone a heroic expert, the anaesthetists or everyone, we're not seeing a lot of innovation happening in the hospital. We are seeing lots of university collaborators, lots of people locked in at home want to come and help. That's where we can get some of these mathematical modeling done quite well. But it is a very interesting time to not maybe lots of things have changed. I don't know what other people's experience have been. Mostly people have retreated into their own areas of expertise and don't really want to collaborate, look at different things.
Thank you.
One final remark, however, though, I do want to also make another remark. The images are absolutely fantastic, but in those images, we have not yet been able to show that the COVID viral particles are contained in those images. So
absolutely right. Absolutely right. And I mean,
so a word of caution, just to interpret the images.
Absolutely right. But I think for other reasons, we should be more careful about carbon dioxide too. I think that's something that the nursing groups have been very clear about for decades.
I agree 100%. And I
Yes.
also share the fears of Professor Abela. The medical legal issues are something that we have to really think about and try to solve.
Okay, thank you very much. We have online Professor Leon Maggiore from Boujon, France.
Yeah.
And I would like to extend a special thank you to him and to Prof. Fingerhut, because Professor Maggiore kindly accepted this talk on IBD surgery after having a original speaker coming with a problem to talk about it, so he could not talk, and Professor Maggiore accepted that in less than 24 hours. So I would like to thank him very, very much and to invite him to give us his talk.
You're very welcome. Can you hear me?
Yes.
Yes, perfect. So it's an honor to be here. And I'd like to thank you and to thank Professor Fingerhut for the invitation. It's always nice to see my mentor, Professor Fingerhut. Hi, how are you? Hi. So I prepared some slides on IBD surgery and especially IPA complications. So maybe I'll try to put my slides in. Let me try. Oh my God.
Max, is for me. No, okay. Right.
It's not working, obviously. Oh my God. I'm sorry.
You just...
On the bottom of the, en bas de l'écran, tu as un truc qui est partager l'écran.
Yeah, that's what I'm trying. And then, why? Where is it? Here. Oh my God. Sorry.
Max. Yeah.
I think I will try to quit and come back. Just a sec. I'm sorry.
You first start your PowerPoint and then share the screen.
PowerPoint is in, but it's not showing. I don't know why.
Okay.
Let me try again. I'm sorry.
Okay.
It's okay.
Is it?
Yes, it's okay now.
I got it. We got it.
Okay. All right. So I have some slides regarding IPA complication. Obviously, I won't be talking about COVID at all during this presentation. I hope you will forgive me for that. So we're going to talk about IPA complication and their management. Okay, so I have something like 40 slides. I will try to be in the 20 minutes that you allowed me. So as you all know, IPA is the gold standard procedure for ulcerative colitis, for familial adenomatous polyposis, and it's also performed for other indications and more rare indications like Crohn's disease, which is now in the European recommendation, for Lynch syndrome, for other very rare conditions. And obviously, it's a complex procedure and it's associated with a lot of complication. We're going to talk about this in this talk. And we're going to talk about short-term complication, which is hemorrhage, anastomotic leakage, obviously, mid-term complications occurring within the year, let's say within the year following the procedure, which is the twist of the anastomosis, pouchitis, chronic leakage, and small talk about long-term complications with stenosis, crowns, pouch dysfunction, and finally the outcomes of redo pouch surgery. So let me start presenting the rates of these complications. Are these rates really high? If you look at a published review, two important published reviews, which were recently published, one on the left on the screens from the Mayo Clinic, and on the right, the Cleveland Clinic, which are obviously really expert center. You can see that the incidence of anastomotic leakage is around 5-10%, which seems a bit low regarding to my experience, but it's maybe because I'm a less experienced surgeon than them, and anastomotic sinus around 5 to let's say 8 or 10%. If you look at small bowel obstruction, it's a bit higher. Let's say 15% of the patients will experience small bowel obstruction due to the adhesions during the postoperative period. Pouchitis is raising around 40% of patients at 10 years, which seems really high, but it's for including all indications of IPA. And obviously, this might lead to pouch failure, which is reported to reach something like 5% of patients in those two reviews. Obviously, those complications are not equally observed if you split the complications rate between the different diagnoses, the different indication. You can see that one condition is especially associated with a high risk of complication, and it's obviously Crohn's disease, which is associated to a higher rate of complication and especially higher rate of pouch failure and pouch anastomotic leakage. So the first thing is how to prevent those complications. What can be done before surgery in IBD patients to minimize the risk of complication? Well, it's obvious, and it's really well documented and really well recommended in especially the ECHO recommendation, which is the European guidelines regarding IBD. The first thing is to wean patients from anti-TNF therapy and steroids to try and achieve nutrition in those patients. And if this cannot be done, especially in patients which are really associated with colitis, active colitis, then you should adapt your procedure and maybe perform a stage IPA here, because as you all know, IPA can be staged in several steps. Maybe the easier strategy is a 3-step strategy, which including a first subtotal colectomy, then a completion proctectomy with IPA, with a diverting stoma, and then the stoma closure. You have the 2-step procedure, which include a total proctocolectomy with IPA and then diverting stoma closure. And those classical 2 steps are now, there is an additional 2 additional strategy, a modified 2-step, because some surgeons now try to perform IPA without diverting stoma with encouraging results. So the modified 2-step is a subtotal colectomy and then a completion proctectomy with IPA without diverting stoma. And obviously, the more risky procedure, 1-step IPA, when you do everything without diverting stoma, which is, in my experience, a bit rare, but can be done and was reported in several publications. So, short-term complication. The first thing is postoperative hemorrhage. It's reported to occur in something like 3 to 5% of the patients. Obviously, the first problem is intra-abdominal hemorrhage, as always in surgery. And there is nothing specific to say about this regarding IBD patients. You should maybe go back to the OR to fix everything. But a specific hemorrhage in IPA surgery is the pouch hemorrhage, which can especially occur on the staple line of the pouch or on the anastomosis, because as you all know, there is a lot of stapling line on pouch surgery. And this is quite frequent in my experience. We have quite a lot of patients with pouch hemorrhage during the 2 to 3 postoperative days, and this is a bit problematic. So what can be done to manage this pouch hemorrhage is a simple transanal pouch irrigation with a cold serum. Obviously, there is a problem because you need to put a probe, transanal probe, to do this irrigation, and you will always have the fear to destroy your anastomosis when you put that probe transanally during the postoperative period. So what we do in my team is that we put the transanal probe during the procedure when we are doing the pouch under general anesthesia, and we keep that probe for 4 days, just because if you have an hemorrhage, you will already have the probe, and there will be no problem during the irrigation. Obviously, the second problem is acute sepsis, anastomotic leakage. You have a lot of points where the anastomotic leakage can come. Obviously, the anastomosis itself, I mean the ileoanal anastomosis by itself. This occurs in something like 13 to 25% of the patients. You have the pouch above the anastomosis, and especially the tip of the pouch on the stapling line on the pouch or at the tip of the pouch, as you can see on my small schematic here. And obviously some rare sepsis are occurring from under the pouch. And this is especially true if it's done in Crohn's disease patients. You can have some postoperative perianal sepsis occurring from, in fact, Crohn's fistula. And this is really a problem, obviously, because this might lead to a higher rate of pouch destruction. So the strategy to manage this acute sepsis is obviously to try and save the pouch, so to perform a diverting soma if it wasn't done during the surgery, antibiotics, drainage, obviously. So we have now, you all know about CT-guided drainage, transanal drainage. We have now a relative new kind of drainage, which is the endosponge. So the endosponge is some kind of negative pressure therapy inside the anastomosis. So it can be done transanally. You put the device transanally through the leakage, and you have to change the thing. There is a suction of the pelvic sepsis, and you have to change the device every 48 to 20 to 72 hours, and then you can close the anastomosis defect when the sepsis is under control, thanks to the device. We have some publication on this kind of strategy. This is reported from the Amsterdam team, Willem Bemelman, and as you can see, it was published relatively recently, last year in GCC. And what they did is that they compared the management of IPA leakage from a conventional strategy, including CT-guided drainage or transanal drainage, to endosponge strategy. And the important thing is that they reported a significantly higher rate of anastomotic closure, fistula closure at the end of the day in the endosponge group, and this was achieved in a shorter time than in the conventional strategy. So this strategy seems encouraging and can be performed easily in a lot of centers. Sorry. I will skip this just to gain some time. Another problem is the twist of the pouch. The twist of the pouch is obviously a surgical problem. When you do the anastomosis, it can easily, especially during a laparoscopic approach, performed with a twist around the mesenteric pedicle. As you can see, this is one of my patients. I'm really sorry to be able to show that picture, but this was a patient who had an IPA surgery, and as you can see on the screen, the mesentery is twisted on 180 degrees around itself, and you have a problem here because you can have have some small bowel obstruction due to the twist, and this is really problematic for the patients, obviously. Two things can be done in those patients. The first thing, obviously, is to disconnect the pouch anal surgery, untwist everything, and then redo the IPA anastomosis. The problem is, as we will discuss, this will be associated with problems regarding the functional results because you are redoing the anastomosis. But the second technique, which is really interesting, is to untwist everything, just doing a small bowel section above the pouch, and to reanastomose everything, leaving the mesentery twisted, but it is not associated with some kind of risk of ischemia. At least no one published or reported a case of ischemia after that kind of strategy, and this will solve the problem of the small bowel obstruction post-operatively. I hope you can understand everything on my small designs here. It's a bit complicated, but I think it's really interesting. Regarding long-term complication, first thing, obviously, is small bowel obstruction due to adhesions. There is no specific strategy regarding the management of small bowel obstruction in IPA patient. The only thing is that you will have to be very careful and to fear about the ischemia of the small bowel, because obviously there is nothing else than the small bowel. So this can lead to a pouch ischemia and pouch necrosis. So you need to go to the OR as soon as possible in patients with adhesion. The only thing to prevent those adhesions is to do a laparoscopic approach. This was well shown in a lot of papers, and especially this one, which was published in the British Journal of Surgery in 2012. Laparoscopy is associated with a lower risk of adhesion and lower risk of obstruction due to those adhesions. The risk factor, if you look at only laparoscopic IPA patient and you look at the risk factors for small bowel obstruction due to those adhesions, this was a multicentric study between French centers and Italian centers, and what we have shown is that the risk factors are short-term morbidity after the IPA surgery, especially septic morbidity, stoma-related complication, postoperative hernia, obviously, and the only variable which were associated to a lower risk of adhesion was the primary subtotal colectomy. I don't know exactly why, but it's the data. So if you look at this, you can see that if you want to reduce the risk of small bowel obstruction due to the adhesion, you have to do a primary subtotal colectomy and to avoid a stoma. So knowing this, maybe the modified two-step strategy is the best option regarding the small bowel obstruction. And obviously this was in the study associated to the lower risk of small bowel obstruction, which was only 4%. So now anastomotic stenosis. I will try maybe to talk quickly about that. There is some risk factor, and especially Crohn's disease, obviously, which are associated to anastomotic stenosis. For the diagnosis, you can do in most of the time the diagnosis through a digital rectal examination. You should perform an MRI and especially a pouchogram to try and assess stenosis just above the anastomosis on the pouch or on the afferent limb, and you will have some images that you can see on your screen of stenosis above the anastomosis. So the idea to manage those stenosis is obviously to do a step-up strategy, not destroying everything immediately. The first thing is to do a digital rectal examination with dilatation, and then you can learn, teach your patient to do some autodilatation to manage the stenosis. But obviously, if you have a stenosis above the anastomosis, this will not be sufficient. So you will have to do some endoscopic dilatation. There is not so much publication on the outcomes of endoscopic dilatation following IPA. And you can do strictureplasty. Strictureplasty were reported to manage pouch stenosis, as you can see on your screen. And obviously, it's associated with a significant rate of pouch loss, but not so high, only 17% of pouch loss at 5 years following the stenosis. A very difficult and complex problem is ileovaginal fistula following IPA, obviously. The idea is that you will have to do some kind of step-up strategy, as in all rectovaginal fistula, trying to start with vaginal flap and then step up with more complex procedure. You can do some muscular interposition, gracilis interposition, which were reported in that indication. And obviously this can lead to the indication of a pouch revision, complete redo IPA, because this is associated with a really, really impaired function and really low quality of life in those patients. I will skip this. One specific surgery, procedure which was described to manage that kind of things, is the pouch advancement. I will talk a bit about pouch advancement in the management of cupitis, but initially it was described to manage the ileovaginal fistula. The idea is to do a transanal approach and to do a mucosectomy, and then to do a pouch dissection around the pouch, not with carefully not avoiding to destroy the pouch when you do the dissection. Then you cut the end of the pouch and then cutting the vaginal fistula opening, and then you redo the anastomosis transanally, because if you dissect everything transanally, you can gain 2 to 3 centimeters to do the anastomosis once again after a 2 to 3 centimeter dissection of the pouch and cutting of the pouch. So you can set up everything with this procedure. It's rare, but it has been described and it can be done. I've done this 2 or 3 times, and it can be done, not easily, but it can be done. Obviously, one of the problems of the patient is pouch dysfunction. We don't know exactly why, but a lot of patients are doing very well after IPA surgery, and then one day they are coming to the clinics saying that now my function is not so good. I have an increasing number of small bowel and I don't know what's happening. Obviously, you will have to look for all the things, classical things which can occur after IPA, pouchitis, stenosis, afferent limb syndrome, but you will also have to rule out any kind of mechanical problem, pouch rotation, pouch stenosis. Everything can occur after an IPA, especially the pouch rotation in the pelvis without any kind of real twist, but a rotation of the pouch, which can lead to pouch dysfunction. And this was studied recently. And in fact, pouch dysfunction, it's not a nervous or psychological problem. It's associated to a mechanical problem in the majority of the cases, in 60% of the cases in that study. So you will have to always rule out that kind of mechanical problem. If everything is okay regarding the surgery, regarding the pouch anatomy, then you will have to look out for more complex problem, pelvic floor problems, and maybe do some MRI deficography or classical deficography to look for an anismus or a pelvic floor problem, which can be medically managed with a good rate of success with biofeedback physiotherapists, which can improve really patients' quality of life. I will speak very briefly of pouchitis. Everyone here know what is a pouchitis, but you have on that slide some risk factor which were identified following IPA surgery in UC patients. I will talk a bit more on cophitis. The problem of cophitis is the rectal cuff inflammation, and in fact, it's persistent UC and not neo-inflammation. And in the European guidelines, it's now well shown that you will have to have a maximum rectal length of 2 centimeters. So this is really short. 2 centimeters is short, especially if you do staple IPA, so a 2 centimeter small remnant rectum when you do an IPA to avoid cophitis. On this slide, you have some symptoms, maybe to know what is the problem, pouchitis or cophitis. The only thing is that cophitis is mainly associated with rectal bleeding and on this slide, the medical management, pouchitis is in the majority of the case managed with antibiotics. In the majority of the case, metronidazole or ciprofloxacin is improving the patient really briefly in 3 to 4 days. Cophitis, it's a bit complex. You will have to do some, sorry for the typo on my slides, steroids or 5-ASA, but the problem is that if you have a refractory cophitis, you will have to do a completion mucosectomy or pouch advancement, as we discussed a bit earlier in my talk. And to conclude about IPA complication, few slides on the revisional pouch surgery. I have a lot of typos, I'm really sorry. Revisional pouch surgery, you have several procedures which are available. Obviously, the easiest one, but the more unsatisfactory one is a pouch resection with definitive stoma. You can also do, and I will have some slides on that, pouch repair, maintaining the initial pouch, or obviously redo pouch with a complete new pouch, which is done. So here you have some slides on some designs of salvage reoperation which can be performed. You will have here you have everything. It's a bit complex surgery. It can be done, especially the type 1 in case of bacterial growth in the pouch, in case of you have a very long tip of the pouch here, and this can be easily done, and especially transonally it can be done really easily. Pouch obstruction can be observed. There is on this slide really beautiful designs which were published recently in colorectal disease, last year in colorectal disease, and several procedure, complex procedure, but doable procedure were described in this paper, and it's really interesting paper. I recommend that paper for everyone. And now to finish the results of the redo pouch surgery. This was a really brilliant and really important paper published in 2015, and only the title says it all. Lesson learned over 500 redo IPA surgery. Excuse me. The idea is that redo patch was done in 40% of those 500 patients, but the morbidity obviously is high, more than 50%. But at the end of the day, it's associated with a high rate of pouch survival at 10 years, reaching more than 80% of the cases. So it's in my opinion, a complex surgery, but with good results. Good results. We have recently compared the results of redo IPA surgery versus primary IPA surgery, and looking at the functional results, you can see that redo IPA is associated with a bit increased bowel movements, a bit not so good functional results, but it's not statistically significant in that study, obviously, maybe because of the small number of patients, but it's acceptable functional results. It's not a nightmare for patients to have a redo IPA regarding the functional outcomes. So this is my last slide. Take-home messages: IPA complications, anastomotic leakage in something like 10% of the patient. The principles are what you do after rectal cancer surgery. Pouchitis in 25 to 50% of the patient. Careful of the adhesion, and especially small bowel obstruction because of the adhesions. Pouch dysfunction something can be done in the majority of the cases. Always exclude Crohn's disease in case of problems with an IPA. Clinical examination is the key. Step-up management is the key in the majority of problems. And if nothing can be done, you can have a redo IPA surgery, which is a complex surgery with a high rate of morbidity, but a high chance of success at the end of the surgical history, and especially two complex situations with impaired prognosis, Crohn's disease, and IPA vaginal fistula. Thank you.
Fantastic talk. Thank you so much, Leon. It was really good. Thank you very much. Learned a lot.
Congrats, Professor Maggiore, and thank you for giving us this very detailed update about pouch surgery. May I ask your opinion about a case I am dealing with? I have this 30-year-old gentleman who had pouch surgery 8 years ago under a colleague who had now retired from service. The pouch worked well for a number of years. This was a stage procedure, so initially I had the loop ileostomy. But since the last 2 years, he's been getting recurrent pouchitis. He's been seen by the gastroenterologist, was checked, there are no strictures. He responded to antibiotics, and indeed he had several courses of antibiotics. But obviously after some time, it comes back. They also tried immunologics, but he cannot tolerate that. Is there a role for secondary defunctioning?
So it's a good but difficult question. From the medical point of view, what can be tried is, other than biologic, is methotrexate. I don't know if they tried that, but it can be. It was suggested to be okay in pouchitis patients. There is not so much literature regarding diversion and pouchitis, but we have done this several times in my team, and it seems to improve a bit the problem with pouchitis. Obviously, the problem is that you don't know what will happen when you will do the intestinal continuity restoration. Pouchitis can reoccur, obviously, when you will have some stools and bacterial regrowth in the pouch. But it can be done, at least. I mean, there is nothing wrong doing a diversion in that kind of patient. It will improve their functional results. It will improve their quality of life, at least temporarily, when they will have the stoma. And let's see. If it's okay after the intestinal continuity restoration, then thank God. But we have also done in several cases a redo pouch for chronic pouchitis, which we were not able to manage medically. So this is the last solution, obviously, to do a redo pouch. And in those patients, it went okay.
And in your opinion, what sort of time frame do you think, how long should the pouch be defunctioned? 3 months, 6 months, 1 year?
There is no scientific answer to that question, but in my opinion, something like 4 to 6 months.
4 to 6 months. Thank you.
Okay, we have a question from audience asking why does endosponge improve quality of life from pelvic sepsis compared to conventional methods of dealing with leaks?
It's a difficult question because there is, in my knowledge, there is no scientific publication regarding quality of life comparing endosponge versus classical management. The problem is that it seems to be shorter with the endosponge to achieve leak cicatrization, but the problem is that you will have to go back to the OR several times, and this is impairing quality of life, obviously, as compared to normal strategy. So, in my opinion, if I don't know. In my opinion, I don't know exactly. I don't know. To be honest, I do not use endosponge in a routine basis in my practice. But Willem Berman, I discussed with him about that, is really enjoying endosponge and said that it's brilliant and everything is now resolved with the endosponge. I'm not sure it's true, but maybe. Well, I think there will be some publication on that topic next year. I hope so. Amsterdam will do something about that.
Thank you. I just maybe Professor Fingerhut would agree with me. There is a lot of work in colorectal surgery by Alberto Arezzo, and I think that is his baby. And they have quite a good outcome, but it is in a colorectal surgery for rectal low anastomotic leaks, and they actually do treat the low leaks with an outpatient base, so that the patient does not stay in hospital. However, at least in the local setting, that is still an expensive instrument and device to have. So we don't have much experience neither with that. Any other questions? No. Okay. I would like to thank. I think this is our first training activity after several months, and as you know, we heavily depend on new things brought from outside the country to this small island, and I don't think that we actually have words to thank you for actually sparing your Saturday morning for a benefit of a young people somewhere else in the world. It is very altruistic approach. Even being very good friends, I mean, it takes a lot of your time, and we are actually
very grateful.
No words to extend our gratitude to you.
Thank you very much. Thank you very much.
Prof. Sean.
Thanks, Peja. Well done today.
Thanks for the occasion. You've done a wonderful job of organizing things. That's really good.
I hope you're happy with the setup. After all, your patronage this first.
Oh, wonderful. It worked very well. Very well. Thank you very much.
Thank you.
Goodbye,
you.
everybody.
Bye.
Bye. Thank you.
Au revoir, Léon.
Au revoir.
Bye.